Hi, once again, welcome everybody. Thank you so much for your patience. We're going to go ahead and get started. I would like to go ahead and introduce you to Dr. Anjay Rastogi. He is the director of our UCLA Core Kidney Health Program. He's the professor and clinical chief of the Division of Nephrology, Department of Medicine here at the David Geffen School of Medicine. Dr. Rastogi, go ahead, it's all you.
Thank you, Anita. And I just want to welcome everybody to our very special monthly chat on COVID-19. And I know it's tough for people to participate in the middle of the week, but we actually have quite a bit of participants. We also got a lot of questions already, and I know there are some questions coming in, and we will try our best to answer as many questions as we can. We might go a bit over our normal 5 to 6 p.m. Pacific time, but I think it's totally worth it. And I'm sure there'll be a lot of good information that will be actually exchanged today. And if you have questions, like I said, please keep on putting them in the chat box, or actually try to put them in the Q&A box. As Anita mentioned, this is our monthly chat. This is the green ribbon, and these are the green kidneys. Green stands for kidney disease, actually. So green ribbon is about fighting kidney disease. This is our normal monthly chat. This is me. This is Mark Coronel, our ambassador of the Circle of Core and a kidney transplant recipient. We have Rebecca. She's our wonderful renal dietitian. And we have Jim Cunningham, who's our psychologist. And we'll be hearing from these experts throughout this session today. A disclaimer, as we always put, this is only for your information. Please do not change or make any changes to your care without speaking to your healthcare provider. So it's only for information. This is some of our contact information, our phone number, our website, and also follow us on Facebook. There's a lot of very important information that we post on Facebook on a regular basis. This is our website. If you haven't been there, please do so. You can also ask questions here, and we do update this on a regular basis. So you'll find a lot of information about disease states, about the latest, and also about COVID-19, as you can see on the left-hand side. And these are some of the upcoming dates. The key thing to remember is it's the same day of the month, the first of every month at the same time, 5 p.m. to 6 p.m. And also what's even better is the same link will work for you. So you don't have to keep on getting the new link. You can just join the first of every month. And today's session is a bit different, that will be focusing purely on COVID-19. But in our other sessions, there's a big focus on diet, on psychology, and all the questions that are coming from our audience on different aspects of kidney disease. And this is our mission. Besides clinical excellence that we try to provide at UCLA through different programs, our big focus is on research and education, and obviously outreach. We have Christina Lopez, who's our manager and one of the key people that we have these programs on a regular basis. This is our Green Ribbon campaign. Our purpose is to fight kidney disease and increase kidney disease awareness. And we'll be discussing how COVID-19 has affected our kidney patients. Now, this is our Circle of Core. So Core is our program. Circle of Core is our patient advocacy and support group, and these are ambassadors. It's an amazing group of people. There are many more that are joining this. There's some that I want to point out. The first I'll start is our co-host, Mr. Mark Coronel. So Mark, you want to say a few words?
Hi, everybody. My name is Mark Coronel. I'm a kidney transplant recipient, and I've been fighting kidney disease for 10 years now. I was diagnosed at 26. 6 years of those 10 years were actually the stages, 2 years, almost 2 years on dialysis, and now almost 2 years post-kidney transplant. Now, as an ambassador, our goal is to raise awareness. And one of the key things that we do focus on is that hope, right? To never give up, to always strive. We know the ups and downs of kidney disease and kidney failure, but the mission and the goal is to never lose hope, to educate. Education is key. That's why, as an ambassador, we're always talking to Dr. Rastogi about giving these key points that we need to know as patients and people with CKD, and then to inspire. I think a lot of the webinars that we do really inspire me as a patient, you know, going into my transplant center, asking the questions that I learned here on these webinars. And it's just an all around great feeling to be on this webinar. And without further ado, I'd like to introduce to you guys Tammy, who is also a core kidney ambassador from the donor side.
Thank you, Mark, and thank you, Dr. Rastogi, for having me on tonight. Together, as Mark has said, we pulled together in support of the UCLA Core Kidney Health Program. And a lot of us, as Mark said, we tried to help instill hope in our patients. We help to support the patients, but we also have a big focus on participating in the community education that is such a big part of what this program does. I came to the role of this by way of having a husband who went into kidney failure, and I had the opportunity to donate to him. And through that, we've had the pleasure of working with Dr. Rastogi and his team, and it was his dedication to provide this education to all people around the world that drove me to get involved, because I learned in our experience that the more we knew, the more confident we felt, the better decisions we were able to make for the health of ourselves and our family. So tonight is obviously about COVID, which has been a somewhat unique experience for each of us. For my family, COVID has been difficult in the way that we share with about 3 in 100 people in America who are living with immunosuppression. Both my husband, due to his kidney transplant, and my 16-year-old son, due to an autoimmune disease, have to have their immune system suppressed by medication, making their risk for serious case of COVID. My husband has also been going through cancer treatment during this, and we've had many difficult decisions to make, as you might imagine. So I found it very important, again, to have access to health information you feel that you can trust, to base those health decisions on for me and my family. And that's exactly what I hope for you today, is to be, that we can be a source of information with whom you can have a discussion, so that you can feel confident you are making the right health decisions for yourself and your family. So thank you for joining us.
Thank you, Tammy. And there are a couple of more points that I want to mention about Mark and Tammy and the Circle of Core. And I know quite a bit of our members are on right now, is the service that they provide. It's a volunteer work, and I know they have called one-on-one to speak to people, to walk them through what the living kidney donation looks like, what's for the recipient, pre-dialysis, post-transplant. So we're extremely grateful. And I think that's one thing, if you can ask what's a standout feature for, or something that differentiates our core program, is our Circle of Core. And that's what we are very, very grateful. I also want to mention the ESRD network. We have Anne and Susan on today. And it's been amazing working with the network. They provide a lot of education, a lot of resources, and always available. And we'll be working with them on several projects that we're rolling out. So with that, before we get into our main topic, I want to introduce our next speaker, and her name is Miss Colleen Flannery. And Colleen Flannery and her entire family and daughter Caitlin go way back as well. So let me give you a bit of background of Colleen. Colleen was a first, if I'm not mistaken, voucher donor. And there's a whole thing about being a voucher donor. You don't donate in advance. And on behalf of somebody, and that person will, if they ever need a kidney, they have a voucher and they can use that voucher. That was the whole idea behind the voucher program. And Colleen was one of our first, if not the very first, voucher donor that gave a kidney on behalf of her daughter, Caitlin, who's actually my patient and has 80. There she is. Always a beautiful smile, Colleen. So I was just giving a bit of intro. So there you go. You can take it from over here.
That was great. Yes. All right. So thanks to Dr. Rastogi doing community outreach about 9 years ago, my daughter and I, Caitlin, had been diagnosed with polycystic kidney disease, which eventually, probably in her case, would end in end-stage kidney disease at some point, but possibly when I would be too old to donate. Knowing what I knew about kidney disease, I also knew I wanted to donate at some point. And so when the voucher program came along, it was just a very natural decision to make once it became apparent that Caitlin would not need my particular kidney because she wasn't in need now, and I was advancing in age, chronologically gifted. And so totally trusted UCLA, really based on meeting Dr. Rastogi 9-10 years ago, because he came to a PKD event and just impressed us so much with his education. And he's just been such a great caregiver. So I knew I could trust UCLA to be a place where I could donate my kidney, and because of Dr. Rastogi. And so then enter my kidney recipient was going to be someone I didn't know. And Dr. Rastogi and my family, Caitlin was there. After I was able to meet my recipient the next morning at UCLA because she agreed to meet me and I wanted to meet her. And Dr. Rastogi was there for that meeting. And sorry, I'm gonna be getting a little emotional and you'll understand why in a minute. It was very special to meet her family. My older daughter, who was not going to be a voucher kidney recipient, described it as magical, and that's just the best word. And we just felt a connection with Maria and her family, and my family felt it. And we've since seen her at a kidney fair with her family and my family. And then we did the 4th of July parade together, and just, I got to see her get better and better. And she was so well, and I watched on Facebook as she had 2 babies born since the kidney transplant. And the very sad thing, the reason I'm getting very emotional, is because Maria was placed on a ventilator last Thursday, and her daughter Maritza texted me and asked me to pray for a miracle, that it wasn't looking good. Friday morning, Maritza called, and it was so beautiful. The way she described the 2.5 years, how grateful they were. She said, this is not going to end well. It's just a matter of hours. And thanked me for in her darkest hour, she reached out to thank me for the 2.5 years that they had with Maria. And then we got the news Monday morning. Maria hung on for many hours, but she did pass away of COVID Monday morning.
So Colleen, thank you very much. And you are very brave. I mean, we have been texting each other for the last 1 week, and I know it's so tough. But she got those 2.5 years because of you, Colleen, and she enjoyed it. But the reality is, the stark reality is, and Dr. Schaenman will be talking more, is about COVID-19 and how that has affected all of us, directly or indirectly. But Colleen, thank you so much for coming on board. I know you'll be around if there's any questions people can ask, and please give a big hug to Kate. So
I will do that. Thank you, Doctor. Thank you. And also thank you to all healthcare workers who are working through all of this. We appreciate you so much. And thank you for all that you do, and everybody stay safe. Thank you,
Colleen. Thank you very much. So I think that really puts in perspective our presentation today, and it's my real pleasure, my privilege, and my honor to introduce our key speaker today, and that's Dr. Joanna Schaenman, a very dear friend of mine and a colleague. Dr. Schaenman is an infectious disease specialist, but within infectious diseases, she specializes in transplant, and she's a full-time faculty in the division of ID in the Department of Medicine. So Dr. Schaenman, I will give it over to you so you can start sharing your slide deck now.
Thank you so much, Dr. Rastogi, for that lovely introduction and for the opportunity to join this really incredible group today. I'm really blown away by what I've heard so far, and welcome everybody in the audience. I have previewed some of your questions ahead of time. I'll try to address them within the framework of this talk, and we will have some opportunity to address other questions at the end. And I'm excited to share my perspective with you on COVID-19. It's been a long 1.5 years. And I should mention that for every slide that I'm presenting here, this is based on either guidelines from the CDC, from transplant organizations, or from published data. This is not my personal viewpoint, but really represents a synthesis of what is out there in the literature. So this is really, I'm the spokesperson for the medical field here tonight. It's truly incredible to look back on these early tweets. I think, like Colleen, it's easy to be upset when we think about all the people that we've lost. When back in 2020, when these tweets began to come out and this information was breaking, I think none of us ever imagined what a year it would be. To think that COVID was the third leading cause of death in the US in 2020, and certainly was much higher than that worldwide. And that here we are, excuse me, in September 2021, still fighting this infection. We certainly have many more tools at our disposal compared with 2020. But I just think it's nice to reflect on what a journey that it's been. So I'm going to speak to you about several aspects of COVID, including some basic biology and terminology, diagnostics, epidemiology, therapy, vaccines, and the impact in patients with end-stage renal disease and kidney transplantation. So a lot of ground to cover. So let me start with just some basic pictures of the virus. I think that we all know in 2021 that the terminology is SARS-CoV-2 is the virus. So it's the severe acute respiratory syndrome coronavirus 2, with coronavirus 1 having, of course, been SARS. Coronavirus is a seasonal virus that causes the common cold. SARS-CoV-2 is so special in a bad way because it is so different from the previous strains of coronavirus. So it's just a shock for everybody's immune system around the world to contend with this new virus in a way that was similar to SARS-CoV-1. And that is the main reason why it causes such severe disease, because it's so foreign. I think if you listen to the news, you'll hear a lot about the spike protein, because that's the target of the vaccines. So just you can see in this cartoon that these little red flowers around the perimeter of the virus is the spike protein, and that's the protein that the virus is going to use to bind to cell surface receptors and invade your cells. So also, if you've looked at the news, we're talking a lot about these viral variants. The one that's really high in our mind right now is Delta. So these differences are based on sequencing of the viral RNA genome. That's how we can determine that they have these different mutations. As you know, the CDC is monitoring these variants of concern and up and coming variants of interest to see whether there's public health implications. And the concern with these variants is that many of them have increased transmissibility, may be able to cause more severe disease, and also now there's a signal that there may also be vaccine resistance. This is certainly bad news, but it's really not surprising. We know that viruses in the community are constantly mutating. It's kind of like, it's not a bug, it's a feature. Their replication process is not perfect. There's not a lot of proofreading when they copy their RNA. So mutants happen frequently. The mutants that convey a survival advantage to the host virus tend to spread within the community. So it's really natural selection at work, unfortunately. And what we really need to do to shut down these increasing variants is to stop transmission of the virus as much as possible. As many of you probably know, the way you get sick with the SARS-CoV-2 leading to COVID-19 is primarily from inhaling respiratory droplets. And this leads to infection of the lungs. There's now very good data showing that masks can be very helpful for preventing this process, especially when the mask is being worn by both the person who's infected and an uninfected person who might be in the vicinity. So when you look at this cartoon, you can see that this woman who is sick with SARS-CoV-2, as she speaks or if she coughs or sings, different particles are going to come out of her mouth. The larger ones are going to fall. Those are the big droplets, but there are small aerosols that can travel over several feet. And when both of these folks are masked, although the risk of transmission is not zero, it's significantly reduced. And that's why masking is so important for preventing disease transmission. In addition, there is now growing data that the smaller the inoculum of virus that you get at the time of infection, the better off you'll be. And one example of that is that early in the pandemic, previously healthy young physicians who were working on the front lines and getting exposed with very high amounts of virus were getting severe illnesses that were probably more related to the amount of virus that they experienced as opposed to some kind of immune deficiency in those physicians. So what happens with SARS-CoV-2 causing COVID-19, it's very similar to any other infectious pneumonia, which is that, as you probably know, within your lung, you have these bronchioles and alveoli that are crucial for air exchange. So as we breathe into the lung, the alveoli, which are tiny sacs, allow for oxygen to get in from the lung to your bloodstream and allow for carbon dioxide to be excreted from your body. So very important function. When the lung sacs get infected, they start to get inflamed. And especially as lung tissue is damaged, this can be caused by direct viral toxicity, as well as by an ineffective immune response to the virus. You get a lot of inflammation. This ultimately leads to thickening of the membrane and fluid in the alveoli. And that's why patients with severe COVID-19 pneumonia often can't breathe and have to be placed on the respirator and be mechanically ventilated, as was mentioned for that unfortunate transplant recipient. Okay, so that's just a little snippet of virology and biology. I think this is familiar information, but just as a refresher, how do we diagnose SARS-CoV-2? The answer is primarily through PCR-based detection of viral RNA in your body. You can see from these two cartoons that the classic way is nasopharyngeal. If you've ever experienced this method of testing, you will not forget it. So basically, you're trying to go not just into the nasal passages, but all the way to the back of the pharynx to try to see if there's any viral DNA present. A more modern methodology is to do a mid-turbinate swab where you're going into the nose, but just really not too far into the sinuses. Although the sensitivity is slightly less with this method, it is much more tolerable. There's also many new diagnostics where you can use saliva, so spitting into a cup or even swabbing the inside of the mouth can be as good or almost as good as the nasopharyngeal swab, which is really the gold standard. Now, I should mention that a lot of these breakthrough infections after vaccination are really based on detection of the virus in an individual and not necessarily based on someone having a clinical COVID-19 disease. So it's important to think about that distinction. Also, if you go to CVS or Rite Aid, you will see many viral antigen tests that are available over the counter. These are sometimes used also at schools and camps. And so you basically swab yourself, typically mid-turbinate, and then you stick the little swab into the hole in the card. And then it's basically going to be diffusing across a little membrane, sort of like a pregnancy test, and give you an answer as to whether you're positive or not. Now, this is detecting viral antigen, in other words, proteins that are part of the virus. So these viral antigen tests, although very convenient and giving you answers within 20 minutes as opposed to within 24 hours, are much less sensitive for detecting virus, especially in asymptomatic individuals. So there's been a lot of attention due regarding antibody testing. And I want to point out the fact that antibody tests were really developed to diagnose past COVID-19 infection. So the antibody test might have an important situation, similar to when we're looking to see, do you have a history of hepatitis B, for instance? You're going to check an antibody test for that. The sensitivity does decrease over time, as the natural antibodies do tend to wane over a period of months. And it's really important to remember that these antibody tests are not standardized in any way. They differ on their sensitivity, on their quantitation, or whether quantitation is even offered, as well as their antigen target. Some of them look at the membrane protein, some at spike protein, which is part of the vaccine, and some at subunit of the spike protein. So if you do an antibody test at ViraCore or Quest or UCLA or somewhere else, the answers are not comparable in any way because it is completely not standardized. In addition, and I'm going to make this point again later, these were really developed to determine history of previous infection, not to determine efficacy of vaccination. So the use of antibody tests to determine whether your vaccine was effective outside of a clinical trial is not recommended. Okay, we don't know at this point in time whether these antibody tests can predict protection from vaccination. And furthermore, we don't know what's a good titer. We don't know what's the right target, and every test is different. You've probably heard a lot about quarantining and isolation. CDC is continuing to recommend that for a non-immunocompromised person, that 10 days after the symptoms first appeared, assuming that the symptoms, namely fever, has resolved and their symptoms are improving, that they can be with others and come to clinic after 10 days. The recommendation is that for those with a weakened immune system, and that would include transplant recipients, that one should wait 20 days after symptoms begin. And that's because we know that people on immunosuppression are likely to shed virus for longer than non-immunocompromised individuals. Okay, epidemiology. So this is hot off the press from our COVID in California dashboard. So apologies for those of you who are not currently in California. This is the state of the state as of August 30th. I just checked right this evening and it hasn't changed too much. You can see that the incidence of tests currently is very similar to our second wave, which was July 2020, which was a bad time in terms of hospitalizations. We're not even half as bad as we were in December 2020, January 2021, where we experienced the most severe pressure of rising COVID cases, hospitalizations and ICU admissions and deaths. Things are better than December, but unfortunately the rate of increase continues to slowly tick up. I've not yet seen these numbers start to go down again. So the rate of increase may have slowed somewhat, but we are unfortunately still increasing. And I think it's really important whenever we're talking about COVID, especially in California, that we recognize the fact that the majority or near majority of these cases and these deaths have occurred in the Latino population. Throughout the country and throughout the world, often minority populations have been harder hit by COVID-19. So I think that's just an important point to keep in mind. The solution to this pandemic is definitely vaccination. We need to get to at least 80% or ideally 100% of vaccination so that we can really slow and stop the spread of this infection. We're currently at almost 70% in California. We're a little bit ahead of the curve in terms of the US, and you can see that LA County has the most number of vaccinations, but no question that we could do much better. There's also no question that when we look at the hospital census at UCLA, it's basically composed of two populations. We've got previously healthy, unvaccinated persons who have COVID-19 severe enough to warrant hospitalization. And we have vaccinated, immunocompromised, or older individuals who have been vaccinated but have breakthrough infections. So even though we are seeing some breakthrough, there's again no question whatsoever that the vaccine is protective against severe disease. And I'm going to touch on that point again in a few slides. Okay, how about COVID-19 in our population of interest, which is end-stage renal disease and transplant recipients. So as I mentioned, there's several reports showing both an increased viral load and prolonged viral shedding if you look at transplant recipients on immunosuppression compared with non-transplant recipients. So that really suggests or reinforces the idea that the immunosuppression that we use to prevent rejection does impair the immune response to COVID virus. In addition, after natural infection, as well as after vaccination, both the antibody and T cell immune response are detectable, but the onset appears to be delayed or possibly lower compared with non-transplant patients. So this is unfortunate news, but certainly not surprising, just showing that immunosuppression is effective for preventing rejection, but also leads to increased vulnerability to infection. When we look at studies of transplant recipients, and although these are primarily kidney transplant recipients, they include other types of solid organ transplant. This was one of the better done studies at a very large medical center in the southeast of the United States that involved several different hospitals. What they found is that when they matched transplant with non-transplant patients based on demographic and laboratory values, including white blood cell count, there was a twofold increase in the odds of death, a twofold increase in the risk of acute kidney injury in patients with COVID, as well as a 1.5-fold increase in the risk for ICU admission. And this and several other studies have also identified chronic kidney disease, as well as lung disease and heart disease, as associated with increased disease severity in terms of ICU admission, intubation, and death in patients who are transplant recipients. There's less data for end-stage renal disease patients exclusively. As I mentioned, although several studies looking at comorbidities associated with risk for severity have identified end-stage renal disease, I thought I would present this data from Europe, where they looked over multiple countries and they were able to identify almost 1,000 patients who were hospitalized with COVID-19. And they found that the 28-day mortality for patients requiring hospitalizations was 21% for kidney transplant recipients and 25% for patients on dialysis. When they did a analysis adjusting for sex, age, and frailty, they found that increased patient age was really the most important risk factor for death. It was actually even more important than end-stage renal disease or even transplant status in this cohort. And this is compared to similar cohorts at similar times in Europe, where death rates range from 10 to 20%. Now, these mortality rates are soberingly high. I want to point out that this is 2020 in Europe. These patients were receiving hydroxychloroquine or nothing. So this is before the modern era of COVID treatment. Our current mortality incidence at UCLA for kidney transplant recipients, as well as the general population, is approximately 10 to 15%. So we're doing much better than we were back in 2020, but certainly we could do a lot better. 10 or 15% is still a shockingly high rate of death in a modern tertiary care center, and it's similar to other hospitals. So what can we do to treat and prevent COVID-19? I'm just sharing these emojis. As you may know, up to this summer, the only needle emoji was full of blood, with blood coming out of the syringe, which is not what you really want to see as a physician. So I'm really glad that they have replaced that with a more neutral image showing some kind of hopefully beneficial solution in that syringe. So that's good. Okay, so this is a table adapted from the Infectious Diseases Society of America practice guidelines with input from the CDC, as well as the American Society for Transplantation guidelines. There's really growing data that hydroxychloroquine is not effective at any stage of infection, nor is it effective for prevention of disease. There have been multiple trials. Many of them were well-powered and multi-center. I think it's very clear that this is not an effective therapy, and furthermore, that there are risks associated with hydroxychloroquine use. In addition, there's really not good data supporting the use of ivermectin. Studies that you may have seen online are generally not well designed. In other words, they're not placebo controlled, and they're generally very small cohorts. I don't think there's any reason to believe that ivermectin has any utility for treatment or prevention of COVID-19. The main therapy that has shown benefit in reducing mortality in hospital stay is corticosteroids, specifically dexamethasone. There's excellent quality data from multi-center studies from the United Kingdom, from Brazil, from the United States, showing that corticosteroids, more than any other intervention, can improve your chances of getting out of the hospital alive, either for patients who are hospitalized with moderate disease and oxygen requirement, or especially for patients with severe disease, patients who require intubation if it's given within the first day or two after that escalation of care. Very significant improvement in outcomes compared with not using corticosteroids. Tocilizumab is an IL-6 inhibitor that you may have heard about. I would say that there is now some data that for hospitalized patients with moderate or severe disease, that it may improve mortality rates as well as time to extubation. However, its role in the setting of transplant recipients who are already immunosuppressed remains unclear. We often do not recommend this medication for patients who are already on immunosuppression because of the concern for secondary infection. Now, convalescent plasma had a lot of attention about a year ago. It really has not held up in high quality studies to be effective in the general population. However, it may still have a role in the setting of transplant recipients, especially those who may have an impaired immune response. It's generally well tolerated. It's similar to intravenous immunoglobulin. And so we do sometimes use that intervention for patients who are immunosuppressed. Remdesivir is an antiviral medication that has shown some modest benefit in terms of time in the hospital, time to getting off oxygen, but not mortality. It is a relatively safe medication. The current recommendation is to use a 5-day course of therapy, and we are using it routinely for patients who are hospitalized with moderate or severe disease. So to recap, the modern cocktail for a patient who's sick enough to be hospitalized and require oxygen, especially with high flow O2 or intubation, is the cocktail of remdesivir and dexamethasone or steroids. In terms of prevention of severe disease, there is now growing data that monoclonal antibodies, especially combination products such as what's currently on formulary at UCLA, which is the Cosirivimab, Indivimab, can be helpful both for mild disease, for outpatients, or even for patients who are hospitalized with mild disease, especially those who are not requiring oxygen. And the current indication for use of these monoclonals is for patients who are at risk for disease progression. So that would be patients who are older or immunocompromised. And it also currently has an EUA for exposure. So if you're at high risk for development of severe COVID-19 and you have an exposure to COVID-19, that's a high grade exposure, you might be eligible to receive monoclonal antibodies to try to prevent progression to disease. But although these treatments exist and our mortality rates are lower than they were in 2020, things are certainly not perfect in terms of treatment. And as I mentioned, even with the very best medical interventions, our mortality rate is still much higher than we would like for hospitalized patients. So it's really comes down to prevention. And prevention, the hallmark of prevention for viral infections and communicable diseases is really vaccination. I'm so grateful that at this moment in time in the US, we have 3 vaccines that are currently available to the general public. As you know, we have 2 RNA vaccines. So that means that part of the virus's genetic code are placed into stabilizing, it's basically like a resin or suspension for injection into your body. This RNA does not get into the nucleus of the cells, but it is transcribed in the cell cytoplasm, leading to spike protein in your cells. Your body then is going to develop a very strong immune response against that viral antigen. And one analogy that one of my colleagues has used is that it's kind of like going to the gym and training for a fight. So you're strengthening the muscles of your immune system so that if and when it encounters the real thing, it's ready to deal with that real virus. And that leads to less infection and less severe infection. We also do have one inactivated viral vector vaccine. That's the J&J vaccine, which uses an adenovirus base, but it is inactivated. That offers the convenience of a single shot. But I think that most experts in the field would suggest that, especially for a transplant recipient, that we have more data regarding the efficacy of the RNA vaccine. Now, as you all know, the Pfizer vaccine is now FDA approved with this very ungainly name of Comirnaty. FDA approval has been submitted and is currently pending for Moderna, which is great news, and just shows the level of data that we have in terms of millions of people in the US alone have received these vaccines. The safety data is excellent. If 14 million have received these RNA vaccines, the number of cases of, say, Guillain-Barré syndrome is 100. So the safety data is really superb. I think one of the reasons these vaccines are so safe is that because this viral genetic code is foreign to the body, you don't really get cross reactivity against human antigens. So it really seems to cause less safety issues than other vaccines. We also know at this moment in time that the efficacy is excellent, greater than 90% in real world settings. And this is data from the US and also Israel. This was true when these vaccines were first released, when we were really in a wild type setting. Even now with the Delta variant, the efficacy in terms of preventing severe disease remains very high. So although we are seeing some breakthrough infections, they tend to be very mild or asymptomatic, with very few vaccinated patients, especially those who are young and not immunosuppressed, developing severe disease. So really good news. So what does the American Society of Transplantation recommend? The recommendation is that all transplant candidates and their household members or close contacts should be vaccinated for COVID-19. I have to say that having seen so many patients, transplant patients and patients on dialysis, sick and suffering through the first few waves of COVID without a vaccine, now we're seeing transplant patients who are vaccinated coming into the hospital sick. They've often been infected by their household members. So the idea of creating a bubble of immunity around someone who is predicted not to have an excellent vaccine response, I really just can't stress that enough. Guidelines also recommend that after transplantation or any other strong immunosuppression, including chemotherapy, to wait 1 month if possible before the vaccine is given. Hopefully all of our modern transplant recipients have already been vaccinated, but this was a big issue for us back in February and March when the vaccine first became available. Now, because there is concern that, like all vaccines, that immunocompromised patients are not going to have perfect response to vaccination, the American Society of Transplantation recommends that patients should continue to practice COVID-19 safety measures. This includes wearing masks around others, physical distancing, avoided crowded situations. So even if you're in a state where, as a vaccinated person, you don't need to wear a mask, especially indoors, we strongly recommend that transplant recipients continue to wear masks indoors and avoid situations, especially indoors, where taking off a mask is inevitable, such as eating in an indoor restaurant or going to a bar. So the good news is that the vaccine is effective in transplant recipients. The bad news is that it's not perfect. So although you can feel confident after getting your vaccine that you're less likely to develop a severe illness, we really cannot let our guard down until the incidence of this infection decreases more significantly. So what do we know about response to vaccine? A lot has been published on this topic. Here's one example from a lab in France. So they measured antibody response based on a titer using their in-house antibody test. And they found that when they had a matched group of healthy controls, dialysis patients, and kidney transplant recipients, not surprisingly, the antibody response was significantly highest in the healthy controls, followed by dialysis patients, followed by the kidney transplant recipients. However, when they looked at T-cell responses, they did notice that they were actually quite good in the hemodialysis patients, and they're actually not discernibly different from healthy controls. Now, they were somewhat decreased in kidney transplant patients, but T-cell responses, and that's an immune cell, were detectable in the majority of transplant recipients. So although a lot of time has been focused on antibody response, it may well be that the T-cell response is what is most important for a vaccine providing protection against COVID-19 disease, especially severe disease. And that's again why we do not recommend checking those antibody titers, because they can lead to a false sense of security. You might think you're protected, but you're not. Or they might alarm you unnecessarily. Maybe your antibody response is low, or maybe it's not detectable. However, if your blood was tested in a research lab, we would be able to detect T-cell responses. And again, we really don't have good data, especially in transplant recipients, whether antibody levels are associated with clinical protection from disease. Everybody is assuming that they are, and maybe that is true, but I'm just letting you know that we don't have good quality data supporting that assertion at this time. So for transplant recipients, just to summarize, we know that vaccination is important. Currently in the US and in a few other countries, the CDC is now recommending that patients receive a third dose of vaccine, basically as a booster, or just in case the first and second doses did not lead to effective vaccination. And one of the reasons that this recommendation has come to pass is that because the safety signal is so good with these vaccines, the thought of the CDC group that reviewed the data was that the benefits were likely to outweigh the risks in getting vaccination and in getting that third dose of vaccine. The recommendation, because this is where the majority of the data is that if you receive 2 doses of a certain vaccine, the third dose should probably be of the same type. So if you got Pfizer for your first and second, you should probably get Pfizer for your third. However, there is some data suggesting that mixing and matching RNA vaccines or even the adenovirus vector vaccines is probably just fine. So the recommendation of both CDC and the American Society of Transplantation is that if you can't match your vaccine, just go ahead and get whatever vaccine is available. For those of you who might have received the J&J vaccine, don't panic. There's still very good news and data that J&J vaccine is clinically effective in preventing wild-type COVID-19. And there's also some recent data showing that there is good protection against Delta, and that the antibody response tends to persist over time, possibly longer than the RNA vaccines. What to do for transplant recipients who received the J&J, what type of booster they should receive is currently not known, but I'm hoping that we will get some information for folks who are in this situation sooner rather than later. And again, there's no utility of checking antibody levels after vaccination unless you're in a clinical trial. I want to stress again that although vaccination is not perfect, there is data, and there was a recent publication by my friend and colleague, Saima Aslam, who's at UC San Diego, that even impaired immune response confers protection against severe disease and death. So I've seen it with my own eyes in the UCLA hospital. Saima actually went and looked at transplant recipients who were primarily kidney transplant recipients. She looked at their cohort before vaccine was available. She looked at her cohort after vaccine was available. And she looked through the people who either did or did not get vaccinated from February 2021. And what she found was that far and away, those transplant patients who were vaccinated were much less likely to have breakthrough infection or to have any infection, and were significantly less likely to have severe disease compared to those transplant patients who remained unvaccinated. And I think Dr. Rastogi is aware of the fact that we lost 2 kidney transplant recipients, 2 wonderful individuals a month or 2 ago. And for whatever reason, they had not gotten their vaccine and they did not make it. And that was really hard to watch. I want to also say that the media has focused a lot of attention on the impaired immune response in transplant patients against vaccination. For those of us in transplant immunology and infectious diseases, this is not remotely surprising because we already know that all vaccines are not as effective in transplant patients. We know that's true for hepatitis B, for the pneumococcus vaccines, Pneumovax and Prevnar, and for influenza. So I don't know if this is good news or bad news, but I guess the point is that COVID-19 is no different from these other community-acquired vaccines in the sense that half a loaf is much better than none. You want to get that vaccine. It's going to provide some protection, even though the protection is not perfect. And just like influenza, hepatitis B, pneumococcus, Shingrix, DTaP, all of those vaccines should be done before your transplant as much as possible. So that means if you're on dialysis and you're awaiting a transplant or hoping to be listed for transplantation at some point in time, it's imperative to get all your vaccines. You don't want to be getting them when you're on triple immunosuppression. Okay, and that is the end of my prepared slides. At this point in time, I'm going to pause to take any questions that you may have.
Okay, great. Dr. Schaenman, I don't know if we have enough time to answer all the questions because we also got a lot of questions via email prior to this. And Mark and I will tag team and ask you questions and comments. Great. And I know there are a lot of comments coming in as well. But first of all, I just want to say thank you, Dr. Schaenman. This was tremendous. And a point that I do want to make, and Dr. Schaenman and I spoke about this before, this is not my opinion. This is not Dr. Schaenman's opinion. This is the collective scientific evidence that we have. Is it right or wrong? Time will tell, but this is where we stand. And I think that's really important. And the other thing that's important to keep in mind is that there's always risk and benefits. I mean, that's how we give drugs, we give medications. So to say that anything is completely safe is not true, but you have to really weigh the risks. And Colleen shared her, which I would say, very sad story just happened last Thursday. And Dr. Schaenman talked about those 2 transplant patients as well. So I think it's very important that we take this seriously. And I just have a feeling that the winter is going to be, I mean, I didn't think the summer is going to be as bad as it turned out to be, but winter we had to be very, very careful. So, Dr. Schaenman, I think some of them you already have answered, but I'll start with a quick question, and this will come for vaccine as well. The flu season is coming up, right? So let's talk about that and the cold. And there was, a lot of, pretty bad colds that people had over the summer, as well. But then the flu coming up, and first of all, how do we differentiate the cold versus flu versus COVID and the vaccination?
Yeah, that's such a great question. I'm glad you asked that. We were so worried last winter that we were going to have a season of fluvid with influenza and COVID at the same time that did not materialize, likely because we had so much COVID last December and because many communities were still basically in lockdown. This winter, I think we really have no idea what we're in for. A lot is going to depend on how much we can make that COVID curve come down before the flu season hits us, which in California can be as early as October. So I would strongly recommend that everybody get vaccinated against influenza. We haven't seen it yet, but we're very worried about folks who might have the flu and COVID at the same time. There's no reason if you've been vaccinated for COVID not to get your flu shot. And as you know, the current technology for the flu shot, it is year dependent. So every year there's slightly different antigen targets. So we need to get our flu shot every year in order to be protected against the strains that are circulating in North or South hemisphere.
Thank you, Dr. Schaenman. The other question is about the testing, and you went over about the sensitivity and the antigen versus PCR. So if you can just address that again, because that question came up.
Yes. So the PCR test, the sensitivity is 95% and above, especially when a trained individual is performing the nasopharyngeal swab. So if you have either asymptomatic or symptomatic COVID, and you get a COVID PCR test at a reputable pharmacy, laboratory, or hospital, the negative predictive value that if it's negative, that you don't have COVID is very high. Now, that said, you could be early within the incubation window. So if I got exposed to COVID yesterday and I take my test today and it's negative, that really doesn't mean anything. You need to wait a minimum of 3 days, ideally 5 to 7 days, for the viral levels to be high enough in your body to be reliably detected. So PCR is the gold standard, especially PCR of the nasopharynx or nasal turbinate. The antigen tests are much cruder. They're much less sensitive. If the PCR-based tests are 95% and above, the antigen tests are as low as 70% in some cohorts. They perform especially badly in asymptomatic patients. Why is that? That's because asymptomatic patients have low levels of virus in their bodies. So if you're going to go visit an immunosuppressed or elderly individual and you do an over-the-counter antigen test and you feel fine and it's negative, there's still a chance, especially when you live in a community like Los Angeles with high levels of COVID, that you could have an asymptomatic infection. If you have symptoms and you want to start with the pharmacy, it might not be unreasonable to do an over-the-counter test. If you're positive, you'll know you need to follow up with your doctor. But if it's negative and you continue to feel unwell, you should probably reach out to your healthcare provider or to your local Walgreens or Quest and get that PCR test. One way you can tell easily if it's antigen or PCR is that the antigen tests have very rapid turnarounds. The PCR tests generally take 24 hours, if not 2 to 4 days to get the results because they're dependent on sequencing.
Doc, I got a couple of questions. When will the vaccine for children be available?
Yeah, that's a great question. So right now, we're very lucky that we have it for our teens. There's ongoing large cohort testing for elementary age school children. We are all hoping that would be available in the fall. However, FDA has asked those trials to be extended and enlarged to be as comfortable as possible with recommending for children that the risks outweigh the benefits. They feel that they've not gotten to that threshold of data at this point in time. So I think we're hoping for maybe winter at the earliest, but no one has a definitive answer.
Thank you. Now, I also have one last question. My father was in the hospital for 65 days battling COVID, me immunocompromised. How long before he gets released from the hospital can I visit him? And what is that window of time?
Right, that's a good question. So every hospital is going to have different visiting guidelines. So you need to check in with that specific hospital. I think it would be wise to wait at least 20 days from the start of his infection, because he'll be less likely to be shedding at that point in time. But I would say that after 20 days from the first start of symptoms, you'll be wearing protection. And if the physicians there and nurses feel that a visiting is acceptable, I would say go visit him. Hopefully you're vaccinated and maybe you've even had your booster shot, and you'll no doubt be very careful with wearing the PPE, the masks, et cetera, that are provided. But I feel like it's so important to visit our loved ones and spend time with the important people in our lives. So I think it would be okay for you to have that experience. In the meantime, in addition to that, I think hospitals have really woken up and smelled the coffee in terms of providing Zoom and other video conference options for patients who are in isolation. So I would encourage you to take advantage of that, and hopefully that's something that he can be provided with at the bedside.
Great, thank you. Thank you so much.
Thank you, Mark. And I know you have a lot more questions, so I'll just squeeze in a question that came in, and this is about chemotherapy. Let me see where that went. My wife is a kidney transplant recipient who's currently getting chemotherapy. Should we wait for a month after her last treatment before she gets her booster vaccine?
Right, so that's a great question. So it's going to depend exactly what kind of chemotherapy you're getting or she is getting. So you'll want to talk to your hematologist or oncologist about that. Some types of chemotherapy might bind to hormones, or it might be a kinase inhibitor or something that doesn't really impair the immune response. But if it is a marrow suppressing agent, or if it is the kind of antibody like rituximab or other antibodies that suppress the immune system, we would recommend that if that's your last dose of chemotherapy, to wait a month, not for safety reasons, but just to make sure that the vaccine can be as effective as possible for that individual.
Right, and I think that applies to anybody who's getting, immunosuppression and stuff, and talking to the provider. So I think that's great question. Now, the next one, I have a whole list over here about the masks before we move forward. Should we still wear masks? And I know what the answer is, but that's a question that came up.
We all should be wearing masks. It does depend on the situation. A lot of mask wearing depends on one's tolerance for risk. So it's actually a harder question to answer than you might think. I think there's no question that based on the current levels of COVID in California and wherever you are in the US, you can look and see what the incidents are. I think there's very few places in the US where you should not be wearing a mask inside. In other words, we know that transmission generally occurs indoors. So I would strongly recommend that people wear a mask when they're going indoors, because you're going to be with other people. You don't know how carefully they're wearing their masks. You don't know if they're vaccinated or not. And you have no idea if they may have an asymptomatic or symptomatic infection. Additionally, when one is in a crowd, at a service, at a game, waiting in line for something, even if it's outdoors, if you can't maintain a good 6 feet of distance, it's probably better to wear a mask. However, I do think that there's increasing data that few transmissions are happening outdoors in situations where people are able to socially distance. So I think even if you are immunosuppressed, I think it is still okay. Go walk your dog, go for a walk, have a picnic in the park, any place where you can safely distance yourself. I think it's fine to take the mask off and enjoy the outdoors. And I'm saying but what I'm repeating to you are the CDC recommendations on mask wearing. And they do also mention that one should look at the incidents in one's community. So because there have been transmissions in restaurants, I do think that for transplant recipients, it may be a little premature for indoor dining, at least in California. If you don't have kidney disease and you're not a transplant patient and you don't live with someone who is immunocompromised, maybe you might be willing to take that chance for indoor dining if you're vaccinated. But I'm not quite sure that that's the population we're talking about here.
And Dr. Schaenman, the other question is about the type of mask. You know, we have the N95s, we have the surgical, then we have the cloth masks.
Right, right. So I guess it's kind of like, you know, adjusting your clothes to the dress code. If you're in the highest risk situation, like if you're a healthcare provider, you're in the room with the patient who's ill and maybe is coughing, you certainly want to have that N95 on. And that's certainly what myself and Dr. Rastogi are using in the hospital when we're seeing patients who have COVID. Now, when I'm walking around in the hospital, I wear a surgical mask like anybody else. I'm not walking around with an N95. I think a surgical mask is fine, really, for anybody, even in immunocompromised patients, with the exception of airplane travel or other situations where you're indoors for a prolonged period of time. So a mask should fit well to your face. I think we've seen all kinds of people with the, you know, like the mouth mask. That's really not good. If it's got the metal, you want to bend it to your nose. You know, when you put it on, make sure that it's fitting tightly around your face. If you don't like your mask fit, you can always double mask with either a second surgical mask or a cloth mask. So I think that these disposable surgical masks, which are now readily available, are excellent tools. You can reuse them, but you want to be careful about that. If they get soiled, you want to dispose them. Be aware of the fact that the outside may be dirty. My children always put their masks on the kitchen table. You really don't want to do that. You should assume that the outside is soiled and treat it like you would basically a tissue. Now, the KN95 mask, you can get that. They're made in Asia. The filtration properties are pretty good. They are recommended from the CDC. There are certain brands that are listed on the CDC website. I think those are an excellent choice for either airplane travel or if you have to spend a prolonged amount of time indoors. And I think of the cloth mask as more like wearing a t-shirt. So maybe if you're just going in and out somewhere, if you know you're going to be outdoors, like you're going to stand in line outdoors somewhere and you find the cloth mask more comfortable, I think a cloth mask can be very appropriate. Make sure that you're laundering it regularly. Make sure that it fits tightly over the bridge of your nose and under your mouth. So it should really form a seal as possible to protect you from those aerosols and droplets, but it should not be tight against your mouth. So you should still be able to breathe and speak normally. We could do a whole hour about mask fitting, but maybe those are just some comments based on what's on the CDC website and what I think are most important to know. That's a super question. It's not just the mask is somewhere on your body. It should be on your face and as well fitting as possible.
You know, Dr. Schaenman, one second, Mark, let me just make a comment on. So Schaenman, I mean, I think this is actually important because, you know, when you're flying, I see people, you have to wear a mask, but it's on their mouth. Yeah. And as we know, the transmission is happening. I mean, where are we testing it? The nasopharynx, right? We're going into, so it defeats, I mean, there's no point in just keeping it over here. And even over here, it needs to fit, you know, well. So I can't really stress enough that, you know, you lose probably most of the benefit if you're not wearing the mask properly. And I think that really needs to be stressed. So thank you. And the indoor portion, I think, is very important. Mark, sorry to interrupt. You had a couple of questions?
Yeah, no worries. Just to piggyback from the mask, and then now we're going to the hands portion. As a post-kidney transplant patient, you know, they embroider in our head to always keep that mask on the first 3 months, hand wash for 20 seconds and sanitize every time you touch something. What are your thoughts on the hand sanitizing and the hand washing?
That's a super question. I think a lot of people, when the focus shifted from masks, from sanitizing surfaces, a lot of people started to think that hand sanitizing was not important. So although the majority of COVID-19 cases seem to be acquired through respiratory droplets and airborne, there is probably a subset of cases that are coming from dirty surfaces. In addition, there's a number of other infections, including the common cold, including influenza, including all the viruses that cause diarrhea, enterovirus, adenovirus, and many others, norovirus. All of those you tend to pick up from surfaces. So although the mask is really key for preventing infection from COVID-19, I would say hand hygiene is a close second. And furthermore, if you don't want to get any of those other viruses, you absolutely should be doing hand hygiene. Every time you touch a common surface, like a doorknob, or anything else that others are touching, bring that gel with you or use that gel that you see around and clean your hands. And that way, when it's time to touch your face and take that mask off, you'll have clean hands. So thank you for mentioning that, Mark. I should add that to my slides. We still do recommend the hand hygiene.
Thank you.
So the next question, actually, there was a question that came up on the mask, Dr. Schaenman. Is there a time limit on using the N95 mask as number of hours perhaps, or no time limit?
Yes, I'm not sure I can quantitate it, but there definitely is a time limit. It has more to do with wear and tear. So if it starts to look a little beat up, or if you think that the outside has become contaminated, you're going to probably want to replace it. It's hard to give a one size fits all recommendation, but you do want to be aware that all of these disposable masks do not have an indefinite lifetime.
Great. The next question is actually, I'm not sure if you touched upon this, is when should you get vaccinated if you just had COVID?
Yeah, that's a good question. The CDC does not have a firm time limit on that. The recommendation is 3 months after you've gotten monoclonal antibodies or convalescent plasma, but we really don't know what's the right time to wait, if any, after you've had a natural COVID infection. I can tell you a few things. Certainly you want your symptoms to have resolved. That's just good common sense, and that's true for every vaccine. If you have the flu and you didn't get your flu shot that year, you don't want to be getting that vaccine while you're still sick. So you want to have recovered. However, I can also tell you that there's increasing amount of data suggesting that natural immunity is inferior to the vaccine-induced immunity. When you look at countries that got overwhelmed by these mutant strains like Delta and even Alpha, like South Africa and Brazil and other parts of South America, many of the cases were in folks who had initially been infected. And this is a big problem in India right now too. Our hope had been that the natural infection would provide lasting immunity. That does not seem to be the case. So although we don't have firm data to guide when you should get that vaccine, we know that it is important. Even if you had natural COVID, regardless of how sick you were, you need to get vaccinated at some point in time. I think a lot might depend on whether how severe your symptoms are, how long to wait. But I would say maybe somewhere in the 1 to 3 month time point is when you want to get that vaccine. Somebody mentioned in the chat that the natural immune response is stronger. That may be true in terms of quantitation of antibodies and T cell response, but I'm not talking about a test tube assay. I'm talking about clinical protection against infection. And if you're asking that question, am I clinically going to get sick with COVID? The answer is clear from the epidemiologic data. Natural infection does not provide lasting protection. Vaccination is your best bet.
Great. Thank you. Thank you, Dr. Schaenman. I think that was an important, and in the same line, I mean, this is another, and probably touched upon this, can we still transmit COVID as carriers even though we are vaccinated?
Yeah, so unfortunately, the answer to that question is yes. I think we had hoped initially that the answer was no, but there have been several documented cases where vaccinated recipients, and I'm talking about average individuals, not even immunocompromised patients, did seem to be able to transmit COVID to others. What I can tell you is that the severity or the viral burden does appear to be lower in vaccinated folks versus unvaccinated. In other words, if you were going to have a sleepover party and one person is going to have COVID there, you'd rather it be the vaccinated person because they're going to have lower levels of virus than if you had an unvaccinated person with COVID, God forbid, in your house overnight. But the risk is not zero. One of the reasons is that, as you may recall, we're vaccinating against the spike protein. That is important for virus entry, but being vaccinated does not prevent you from inhaling this viral pathogen, right? So it's not blocking all transmission. It's blocking the virus being able to set up shop in your body and create a productive infection that leads to you getting pneumonia. Right? And that's true of a lot of vaccines. It's hard to completely block transmission. So again, it's unfortunate news, but it's maybe not that surprising that you can still be a viral carrier if you've been vaccinated. And that's why we should all continue to wear masks and be respectful of others in the community. I can't remember who mentioned it. Maybe it was Tammy earlier, that even if you yourself are not immunocompromised, maybe the person that you're standing next in line to at Ralph's is, right? Or maybe someone in your household is. So I think it behooves us all, if we don't have any chronic disease, to wear the mask. And just in case, in the off chance that we're an asymptomatic COVID positive person, that we're not spreading it to others who might be in a 6-foot radius of us.
No, I think that's I think it was Tammy, Dr. Schaenman. Mark, you had a couple of more questions that you wanted to ask?
Yes, there was a very interesting one, Doc, that came up. It says, does any of the vaccine affect fertility? If there's no adequate data available, at what point would data be expected in the area of the medical community?
There's a lot of misinformation out there in social media about fertility. You know, fertility and children, those are really hot button issues that make people feel very panicked and very uncomfortable. So first of all, I can tell you that in the whole history of vaccines, the adverse events have have 100% been limited to the first 30 days tops after getting the vaccine. So this fear that there's going to be long-term side effects of the vaccination, we simply have never, ever seen that. Vaccine adverse events tend to be early because that's when you're having that initial immune response that's causing the side effect. So if there was going to be a fertility signal, we would have seen it by now. We've had, as I said, millions of folks just in the US and many more millions worldwide have received this vaccine. We have not seen that. And as you may know, there's something called VAERS, V-A-E-R-S, the Vaccine Adverse Event Reporting System. Anyone who has received the COVID vaccine can go to VAERS and put their symptoms in, or maybe you're answering a questionnaire that you're getting on your phone by text after the vaccine. And what we can say with confidence, I mean, there's always people who are going to put in symptoms like, I got hit by lightning, I fell, something bad happened to me after I got the vaccine. But what we can tell is that the rates of those things happening are no different from the rates in the general population. So literally, if you look at VAERS, people have put in, I got hit by lightning, I'm not even exaggerating, or other somewhat specious things, but nothing is higher than the rate that's seen in the general population. So we have not seen that fertility signal. Furthermore, as I mentioned earlier on in my talk, when I was talking about the mechanism of vaccine action, RNA is just going to be transiently in your body. It's broken down by cell death and the natural scavenging system we have in our immune system. So the RNA, it's kind of like a telegram that's going to be ripped up. It goes into the cytosol of your cells. It's transcribed to form the spike protein that causes an immune response in your body that leads to lasting antibody and T cell and B cell immune response. but then both the RNA and that viral protein disappear. They're going to disintegrate. So the idea that having antiviral immunity is going to impair your fertility, it's simply not biologically plausible. The vaccine does not get into the nucleus of our cells, and it doesn't hang around. For a lot of these somewhat fear-mongering vaccine side effects, I will say, and I feel this very strongly, that you're much likely to have your fertility impaired by getting COVID than by getting the vaccine. And this really goes back to what Dr. Rastogi said, that medicine and life, it's all about balancing risks and benefits, right? Nothing in medicine or in life is 100% risk-free. But what I can tell you is that the risk of any of these safety signals or side effects from the vaccine are so much less likely to occur and cause you lasting damage than the devastating effects that we've seen from COVID infection.
Dr. Schaenman, if it's okay, we'll continue with the questions because
Sure,
there's so
absolutely.
many, and we still have people, and I don't want, we're on a roll. And I know Mark has a lot of questions too, because we discussed that, so he can ask some more. But I think one of the points that you mentioned, which I was going to ask you, and this question has come up several times, these RNA and DNA vaccines, do they alter my genetic code?
Right.
And I think you answered that, but if you want to just say it one more time.
Right. So
yeah.
It's just simply not possible, and we have not seen it. So the genetic code of all humans is encoded in DNA. We and other mammals have a DNA-based genetics, and that's how we pass on hereditary traits to our children, is through DNA. DNA is exclusively located within the nucleus of the cell, which you could think of, it's like the command center of the cell. So in our cell, this is probably more biology than you wanted to hear, but this is the only way to answer the question conclusively. The DNA is exposed when it's time to express a certain gene. DNA is turned into RNA, that's the messenger RNA. The RNA then diffuses out of the nucleus into the cytoplasm. That's where it's transcribed into protein. So it is a one-way system where your nucleus, the command center of your cell, is telling the cell what proteins to make. This allows you to grow new skin, to synthesize digestive enzymes, to grow your hair, etc. This is the natural human biology. If RNA is in a cell, it cannot and it does not get into the nucleus. Even if it did, that's not where transcription happens, so nothing would happen. And that's not where proteins are synthesized, okay? Proteins are only synthesized in the cytosol, and the human cell and the mammalian cell has evolved this very neat way of dividing up these different tasks to prevent errors from creeping in. And that's why it is simply not possible for any RNA product in your body to alter your genetic code. Altering the genetic code is extremely difficult to do. You would really need something that targets DNA and that had some maybe enzyme or something else attached to it that would actually get into the nucleus and alter the DNA. It's not so easy to do. And again, it 100% cannot and does not happen from any of the COVID-19 vaccines.
Great. Thank you so much for that explanation. The other question that's coming up a lot is the full approval versus emergency approval by FDA. And I know, the full approval just came through. So
right. But I think it's still good to think about that process a little bit. It may not be a shock to any of you to know that the federal government has a lot of bureaucracy, and every action requires multiple steps and levels of approval. Partially, this is just the way large organizations work, but many of these are checkpoints that are really designed for our safety. So there's different levels of data and evidence that are required for an emergency use authorization and for full FDA approval. One way to think about this is, if you recall back in March 2020, hydroxychloroquine was for a short time had an emergency use authorization from FDA. At one moment, they said, you know what, we're really not sure that maybe this is effective. Practitioners, you have the green light to try this. in patients who are very sick and dying from COVID, and that was before we had remdesivir dex. Now, what happened to hydroxychloroquine? The data came in that it was not effective, and furthermore, it was causing side effects, predominantly cardiac effects. The EUA was retracted. The EUA system is much more nimbler compared to full FDA approval. So if FDA sees something really dangerous happening, it can put out that EUA, which again is emergency use authorization. So we're saying, hey, there's an emergency here. Even if the data is very good, if the data is not very broad, in other words, if you have a study with 500 or 600 patients, but you don't have a study with 6 million patients, that might be good enough to get that emergency use authorization. I think that was done very effectively and very appropriately by FDA working with CDC. And that's why we have a lot of tools, including monoclonal antibodies, that we're using under an EUA. Now, as FDA goes through their process, they're going to require a certain quality of clinical trials. They're going to require a certain number of patients to be tested on a certain intervention, whether it's a drug or a vaccine. And they're going to require a certain amount of follow-up time before they're going to say, yes, this has our full seal of approval. So even though for months and for the past year, we've had really great data supporting the efficacy and the safety of these COVID vaccines, it was not until this past month that Pfizer managed to check off all the boxes to allow them to say, we've got that stamp of FDA approval. I was just thinking that it reminds me a little bit of the process of becoming a kidney donor or recipient. You know, maybe we know at that moment in the office, we know you're going to be a great candidate. This is perfect for you, but we have a process in place. We have that process in place for a reason. You're going to go through our checklist. You're going to see the cardiologist if appropriate. You're going to get the scans that are requested. You're going to get your antibodies tested. You're going to go through that process. That process slows us down and is sometimes frustrating, but that process is there for your safety so that when you get that seal of approval, we can feel confident that not just one physician, but a panel of physicians and other healthcare providers, including nurses, nutritionists, psychiatrists, et cetera, feel that you are a good candidate. And I think that's a good analogy for the FDA approval process. It's slow, but it's there to almost slow things down on purpose so that we can have maximum confidence in an FDA approved product.
Yeah, and I think that brings back to science, Dr. Schaenman. You know, we do studies, we do trials, and I know a lot of people who are on right now have been on studies, and there's a phase 1, there's a phase 2, phase 3. But at the same time, you know, we also had to put time in context as well, because, you know, exactly. The COVID is a pandemic. It's you are absolutely right. I mean, a lot of things go into an approval, whether it be emergency approval, full approval, but in all stuff that we're discussing today, it's about science. You know, science leads the way, and sometimes we don't have the full answers, but that's okay. We can try to, you know, do an educated guess that this is probably going to be the best response. So the other question that came up, and I think this is a recurring question, is about antibody testing. And I know you have answered this, but let me just put this question in perspective again. I just received my 3rd vaccine. My nephrologist took an antibody test a few weeks ago and said that I have no antibodies. My transplant was 2.5 years ago.
Right.
What do we do here?
Dr. Rastogi, I get this question all the time from patients, from my physician and nursing colleagues. This is a very difficult situation. When we physicians have tests, we want to use them. And sometimes we send tests in a situation where we don't quite know what to do with the answers. So as I mentioned before, but I'm happy to reiterate this, at this moment in time, and as you said, this has really been a moving target. I have updated these slides time and time again. I had to update them again this week because of the Pfizer FDA approval. So what we're saying, I'm talking about what we know and what we recommend September 1st, 2021. We currently do not have information what is a protective titer in terms of antibody testing. We also don't know for sure that for transplant recipients, is a protective titer necessary to be protected against COVID? As I mentioned before, there are other parts of the immune system, including the T cell, that are probably more important for protection against COVID disease. So when you check an antibody test and it's negative, the sad answer is that we simply do not know what that means. You should continue to take precautions anyway, but there's a good chance that you do have an effective T cell response, so you shouldn't panic. But we really should not be checking antibodies because a positive test could create a false sense of security. A negative test could create unnecessary panic and anxiety. So for all of my transplant recipients, I want you to keep wearing the mask, keep being cautious, but get vaccinated, get that third dose. Someone mentioned in the chat that it really should just be called the third standard dose and not the booster. And that is a true point. You want to get those vaccines. You want to maintain your protection by avoiding dangerous situations and wearing your mask. And the real cure for immunocompromised patients is going to be herd immunity. And when the incidence of this terrible infection finally decreases in the general population, that is what's going to save us, not getting our third and fourth and fifth vaccination.
Great. I mean, that's a great point. And, we talk about smallpox, we talk about polio, we talk about a lot of other, and I think we always have to keep those things in mind. And it's a nasty bug. And Dr. Schaenman, you know that, and I know that because we take care of these patients in the hospital. And the effects can linger on for a very long time, for almost ever. I mean, if you go by time. So there's another very good question that came up, which I think people will benefit since, because of the immune response in a transplanted patient or an immunosuppressed, compromised, should they be getting higher doses of the annual flu vaccine than the usual dose? Are there other similar vaccinations where we should use higher doses? And we know we do that for transplant patients, dialysis patients all the time.
That's a super question. Exactly. So for dialysis patients, we use the higher dose of hepatitis B vaccine. We recommend that for transplant recipients as well if they didn't get vaccinated for Hep B before their transplant. There is good data, both in terms of clinical efficacy and antibodies and T cells, I should mention, that the high dose flu vaccine is superior for transplant recipients and other immunocompromised patients, as well as those who are 65 and up. However, sometimes insurance will not pay for a transplant recipient who is less than 65 years to get the high dose vaccine. So although we would prefer that you get that high dose vaccine, the best vaccine is the one that you get. And if the only one that you're able to obtain or pay for is a conventional influenza vaccine and you're a transplant recipient, please get that vaccine. If you're able to get the high dose vaccine, even better. But like so many things in life and in medicine, sometimes the perfect can be the enemy of the good. And even a conventional dose vaccine is much, much better than nothing when it comes to influenza. I do think it would be great if we could one day have a COVID vaccine that was really targeted for older individuals and transplant recipients. As Dr. Rastogi knows, my research with my collaborator and mentor, Dr. Elaine Reed, who runs the Immunogenetics Center, is on T cell dysfunction that results from either age, end-stage kidney disease, or transplantation. And Dr. Reed and we are actively studying immune response to COVID in transplant recipients as part of an NIH study. We're actually going to try to start enrolling patients who are coming to UCLA to get their third dose of vaccine. So maybe some of you will get a phone call from me to ask if you want to be in that study. I think that if we can develop a better understanding of how immunocompromised patients respond to COVID, and what does a meaningful protective response look like in the setting of immunosuppression, perhaps we could design a better vaccine that's either a higher dose, or maybe it has an adjuvant in it the way Shingrix does. So we could provide a superior clinical protection compared to what we have currently.
Great. There's a whole bunch of questions coming in. I do want to get into the monoclonal antibodies. That's in the booster dose, so those two. But before that, one quick question about exchange of biological fluids. Would that put at risk of COVID transmission?
Yeah, that's a really interesting question. We have not seen that convincingly, that this virus can be spread sexually, for instance. However, it's certainly not impossible. And if you're ever in a situation where you're exchanging bodily fluids, you're probably breathing that person's air as well. So it may be hard to differentiate. But I don't know if that person's maybe asking about risk from blood transfusion or transplantation. I can tell you we've not seen it from blood transfusion, probably because SARS-CoV-2 is really not very much in the bloodstream. There have been a few cases of transmission through organ donation. For that reason, all organ donors, both living and deceased, are screened for COVID using a high sensitivity PCR test. There was a tragic and fatal case of transmission of COVID-19 through lung transplantation in Michigan, where the recipient did end up dying. So I do think that it's possible in unusual situations such as organ transplantation, that COVID, SARS-CoV-2 can be spread through bodily fluids. But in general, for the general population, when you're walking around, it's really aerosols.
Great, thank you. Thank you, Dr. Schaenman. A couple of questions on booster dose. And I know you did touch upon this, but I think this question is keeping coming up. When should we get the booster dose? If you want to call it booster dose, and I know a comment came in about the third dose, but let's call it booster for now. What's the right time?
Right. So let's just call it the third dose. And the answer is that we really don't know. Most of the patients who were enrolled in the studies that were performed by Pfizer and other companies that led to FDA and CDC recommending the third dose, those were often patients who had received their vaccines in January, February, March. And then they were getting that third dose in the past month or two. So just the way this pandemic has evolved, it just so happened that the third dose was separated by 4 to 6 months. We don't know, however, that that's the optimal way to do it. So what we are recommending right now is that if you're a candidate for the booster dose, for the third dose, that you can receive that as soon as 30 days after your second vaccine dose. So it's almost like you're getting that second vaccine dose again.
And the second part, you also answered as well, but it came up again, mix and match. I got Pfizer, Moderna, or even the other one, then J&J, which is, the virus vector based.
Yeah, we don't know. So maybe if you ask me back to do an update in a few months, we'll have some data about this. All I can tell you is that there are some case reports and case series where people have mixed and matched, either on purpose or on accident. There has not been a safety signal, and some authors report that the immune response is improved by the mix and match approach. So I would say hold that thought. It may be that we will recommend that in the future. All I can do is repeat again that CDC is recommending, based on the data that was presented to them, and this really represents the bulk of the 3-dose data, is to stick with the horse that you rode in on. So CDC is recommending if you got Pfizer 1, Pfizer 2, get Pfizer for 3. If you got Moderna 1, 2, get Moderna for 3. If you got, let's say, Moderna for the first 2 and you can't find Moderna in your area, they're recommending to go ahead and get the Pfizer if you're in the high risk group. Again, that's because the bulk of the data is with sticking with the same 3 vaccines. It's certainly possible that additional data will surface suggesting that either it doesn't matter, or maybe that the mix and match approach is more valuable. It's certainly possible that we will evolve towards some situation where we do know what immune response we should be checking in the blood. And we can say with more precision, oh, your immunity has waned based on factor X, T cells, B cells, maybe neutralizing antibodies. You should be vaccinated again. We're not there yet. We may also get to the situation where we are engineering vaccines against specific mutants, such as Delta. So it may be that at some point in time, we're all going to get our Delta booster shot. Or maybe like the flu, every year the COVID vaccine might be a little bit different. Maybe we'll get a combination vaccine with COVID and influenza, and both of them will be adjusted based on the strains that are circulating at the time. Honestly, the mind boggles. It's probably not a one and done vaccine, but we really don't have enough data to know what the future will hold in terms of mixing and matching different types of vaccine and whether there's potential advantage there.
And I think Dr. Schaenman is following up that which vaccine should you get? And I think you said that, and I probably will repeat that, get the one that you can get, right? I mean, that's right. That's the key word, get it, get the vaccine.
Absolutely.
And I think that's really on a timely basis. I mean, it's so those booster, and now as we wrap up this hour, because I think we're getting to closer to about the monoclonal antibodies. A lot of questions have, if you can just repeat some key points, who should get it, how soon should we get it? I think there's a question came up that, it's Monday 8 to 5, but I got symptoms at 6 p.m. on Friday.
That's right. So again, the indication for monoclonal antibodies, which are available through an emergency use, an EUA, is high-risk patient with high-risk exposure, or a high-risk patient. That means someone who's at risk for progression of disease. That's defined as immunosuppression, increased age, or comorbid conditions, including diabetes mellitus, lung disease, and obesity. The monoclonal antibodies are now generally combinations. So they are humanized, engineered antibodies that are specific against not just SARS-CoV-2, but the specific SARS-CoV-2 strains that are circulating currently. There is good data now that giving 2 at once is better than 1, because that kind of cuts off the escape route for the virus as it starts to mutate. They have been used to a lesser extent for much sicker patients, like patients who are so sick that they're already intubated, and the efficacy was near 0. So there seems to be some sweet spot early in disease as your immune system is scrambling to get control of this infection, where the monoclonal is helpful. If you're already on the point where you're requiring high levels of oxygen and you're intubated, it's unlikely to help you. So if you have either mild disease or you're diagnosed with COVID and you don't have symptoms and you're in a high-risk group, you should contact your medical provider. Another method for accessing the monoclonal antibody is to go to the emergency room. I don't know whether this is true for every hospital, but at UCLA and many other academic medical centers, if a patient is diagnosed in the emergency room and doesn't meet criteria for admission, so they have mild or no symptoms, they can often get the monoclonal antibody right there in the emergency room. Sometimes it's given IV, but sometimes for time reasons, it might be given in a subcutaneous fashion. I noticed that was a question. There are potential pre-medications that can be used for the IV, so it can take an hour or 2 to safely receive it. But after you're monitored for another hour or 2 to make sure you don't have any adverse events, you're free to go on your way. Now, nothing is perfect in medicine. We've definitely had a handful of transplant recipients who got monoclonal antibodies, but nonetheless had disease progression and ended up coming into the hospital with severe disease. But in general, it's been quite effective at preventing progression of symptoms, much, much better than nothing. And there really is good data now showing that it is safe and effective in patients with early or asymptomatic disease. It is a shame that it is difficult to access. It would be great if we had a more coordinated system across the nation so that people would easily know how to tap into that. We're really not there yet, but it is out there. And if you go to a place that has it through an emergency room, then you would be able to access it Saturday, Sunday. But I guess I would say is that, let's say you're diagnosed Friday, you can't reach anybody Saturday, Sunday. If you call your doctor or reach out to a COVID clinic first day, Monday morning, you'll still be within the window, which is 3 to up to 5 days, where you could receive the monoclonal antibody and derive some benefit from it.
Great, thank you. I know there's so many more questions that we can keep on answering, Dr. Schaenman, but I don't think we have time. We have to bring you back. You know, you've been going on for 2 hours now. One couple of last questions about travel, you know, and we're not there yet, but the holidays will be starting soon.
Yeah, so at this moment in time, I'm still a little bit concerned about travel, especially for transplant recipients. There's you can rank order the dangerousness of travel. I would say the most dangerous type of travel right now is probably international travel, because that means, by definition, that's a long plane flight. And you really don't know what's going on with the other people in your cabin. What's their vaccination status? What's their COVID status? Are they wearing their mask properly? And you're going to have people taking their mask off multiple times during the flight to eat. I do think that one should check the COVID incidence, both in your area and the place that you're going, at the time when you're thinking about traveling. So at this point in time, I was just asked by a transplant recipient about traveling to New England for a wedding of a very close friend. New England, actually, the incidence is relatively low, undoubtedly as a side effect or a consequence of their high vaccination rates. So I said, it's not ideal, but if it means a lot to you, keep that K95 on the whole time during the plane. You're going to an outdoor event in a place where the incidence is relatively low, that's probably okay. So the longer the plane ride, the harder it's going to be for everybody to keep their mask on. And then you want to look at your destination. A car ride is a little bit more controllable. You ideally know everybody in the car, you know their vaccine status, and you know whether they have symptoms or not. But you really need to ask, where am I going? You know, am I going to some desolate VRBO cabin in the woods to enjoy nature? That's probably a pretty safe vacation plan. Or am I going to a family party that maybe is going to be indoors, where I'm really not going to have control over mask wearing, over vaccination status, over infection status? And I think that's why we had such a big spike December 2020. It was Thanksgiving and it was holiday parties, where people who are really desperate to see each other, despite the fact that we were still in lockdown. You couldn't go to a restaurant, but you could go to your aunt's house and have a masks off holiday party. That's very dangerous. So I think we're really going to have to play it by ear, see where we are in terms of COVID incidents, and what do we know about vaccine protection at that point in time. But ultimately, you're going to have to make a hard decision about how important is this event to you? How much risk are you willing to bear? And what actions can you take to make it safer? Could you move the party outdoors? Could you talk to people about wearing masks and try to help them understand that although you're vaccinated, you're still vulnerable? And if you can't control it and make it a safer situation, it might be better to wait it out another year and interact on a video conference such as Zoom, and wait for incidents to decrease in California and nationwide before we do those in-person holiday parties again.
Great, Dr. Schaenman. I know there's so many more questions. I think there were some very individual questions that I, will try to answer them. We're hoping that you come back. We have these chats every month. So we'll see if we can bring you back every time. 2 hours is a long time, Dr. Schaenman. I can't thank you enough. The comments have been amazing. I want to thank, besides Dr. Schaenman, all our attendees today, our volunteers who are spending time, all the supporters. I know Tammy has put in something because there are a lot of questions coming up, how to support, the different ways to support. Reach out to us. We'll find that. Also, Dr. Schaenman, there's some people who want to sign up for your study. So I will make sure that we connect you with those people. So for antibody studies and stuff that you had mentioned. Mark, any passing comments for or comments or Anita or anybody else?
No, Doc, that was it. Thank you so much. That was so informative.
Yeah, but this was amazing, Dr. Schaenman, and I know Jim and Rebecca were supposed to speak today, but I personally think this was, you know, it took a bit longer, but it was every second was worth it. So with that, we'll be signing off. Our contact information is over there. We took all the questions down. We'll try to answer some of those questions individually because some of them were very detailed. The other ones, we're hoping that Dr. Schaenman will be back next month again, not for 2 hours. So we'll make sure that we don't put it. But it's every month we have this chat. First of every month, 5 to 6 p.m. You can put that on your calendar. Saturday, Sunday, Monday, holidays, we're going to have this. If there are other further comments you want, please email us. And if that's all, I want to thank once again the Core Kidney team, the Brewing Beans, all our volunteers, all our supporters, and most importantly, Dr. Schaenman. Thank you very, very much. And we'll see you next month. Bye for now.